All right. Hello, everyone.
Hello.
2-1. Okay. Hi, I'm Dr. Moosavi. This is
Hi, I'm Mike Bonnette.
And we are here again to give you one of our, ongoing webinar series discussion and talks. And obviously, this is open-ended. So if you have questions, please feel free to put them in the chat group. We'll be happy to answer them even throughout, or we might just hold the questions right till the end. But nonetheless, feel free. Today, we're doing something that's going to probably impact most of us and or has already impacted most of us throughout our lives, which is lower back pain, and specifically non-radiating back pain, where you have this pain in the lower part of your spine. It doesn't necessarily shoot down the legs in the form of what we call sciatic type pain. And our talk today is to discuss about some of the treatment pathways for this, as they have been new and good evidence-based pathways that have seemed to show success, not just in older patients, meaning, older in the sense of, above 60 and 70, more even in the 40s and 50s, we're seeing good results with this. So I'll just start with a little bit of a history. So general prevalence of low back pain, as we know, is still a leading cause of disability in the United States. It's a leading cause, a large, extensive cause of loss of work, leading to major impacts on the economy. About 10 to 13% of adults, which equates to about 30 million, have some form of chronic lower back pain in the U.S. So obviously, this is a major issue. And then according to some recent published data, at least 60 to 80% of us will have some form of lower back pain in our lives, whether it's, radiating back pain or just regular kind of non-radiating. That's obviously still within that number. Areas of focus that we're going to do in this quick kind of webinar is we're going to talk about facet pain, which is our small joints in our back, and we'll give a little bit of a more detailed look at that. Discogenic pain, which is pain primarily related to some of the disc issues that we may have, and vertebrogenic pain, which is part of actually the vertebrae. Some of the procedures we're going to touch on is a medial branch block, which many of our patients have been fortunate to have done and have good success with it. And that leads to what we call radio frequency ablation, or RFA, which again is something that we've had good success with for many of our patients. And then more recently, there's been a lot more headway on what's called basovertebral nerve ablation, or BVNA, which is something that's for vertebrogenic pain. And we'll go into a little bit of detail on that and on what we're actually targeting. And lastly, PNS, peripheral nerve stimulation, which is also something that's an implantable device, but can be very helpful for axial or non-radiating back pain, especially for those who fail or don't respond well enough to the above three. We see that good success. And go ahead, Dr. Bonnette.
Yeah, so understanding non-radiating back pain is somewhat of a complicated process for something that sounds somewhat simple. Oftentimes, when we think of back pain, we think of a disc herniation or pinched nerves and shooting pain down the leg. But oftentimes, patients don't come in and have those symptoms. It's just pain in the back itself. And what can we do for that? So first, we want to figure out, what is going on? What level of the back is it? Is it in the lower lumbar spine? Is it in the upper lumbar spine here? Is it related to, flexion forward, extension backwards, different rotation type movements? There can be different mechanical or degenerative sources of these pains based on what our back is like and what either trauma or different impacts we've had on our spine throughout our life. The most common things, as Dr. Moosavi talked about when we talk about back pain, though, that's non-radiating, is we are looking at the facet joints, which are the two joints in the back of the spine that allow us to rotate and extend backwards. And then we're talking about the disc in the front and even the bone in the front, or the vertebral body here. All three of those spots, the disc, the bone, or these joints in the back, all are very common sources of this axial or non-radiating back pain. And when we talk about the facet joints in particular, like I mentioned, these joints allow, there's two joints, one on each side, and then there's these joints at every single level of our spine. As you see here, at each level of the spine, you have these joints. They connect the spinal units there, and they allow us to twist, rotate, extend the back. They allow us to stabilize the spine there. This joint is similar to a knee joint or a shoulder joint, where there is a joint capsule around the joint, and there is some joint fluid in that space there, which can become inflamed, and you can have inflammation that develops in the joint there. This pain is often pain that is noticed most while standing, while twisting, rotating, doing maneuvers like that. And it usually comes about as we age and we develop arthritis in the back there. So oftentimes when someone says, I have arthritis in the back, they're talking about arthritis at the facet joints and pain that comes from those joints there. To diagnose pain that comes from the joints, there's not necessarily a specific exam maneuver. Sometimes patients will have some tenderness over that region of their back, or they'll have pain with movement of the back there. But the true way to diagnose pain coming from the facet joint is to essentially bring a needle down to that joint, inject numbing medication, and see the response. And someone who has pain coming from that joint should have improvement in that pain in the 24 to 48 hours after injecting numbing medication to that joint. And that gives us a way to really target and determine which levels of the back the pain is coming from, or which joints particularly the pain is coming from. Yes, this is called a medial branch block, or sometimes people will call it a facet block, because we are blocking that facet joint. We are typically doing this procedure while you're laying on your stomach with X-ray machine guiding how we bring a needle down to that joint. It is a pretty quick procedure. We use a very small or thin gauged needle, so it tends not to be very painful or uncomfortable to do the procedure. Usually takes about 5 to 10 minutes to do the procedure, depending on how many levels we are testing there. And it tends to give quick results, and we tend to see it within the day after we do that procedure. So oftentimes I will do this procedure for a patient to determine if their pain is coming from a certain level of their spine, and I will call them a couple days afterwards over the phone to ask, did the pain improve after we did the injection? And then oftentimes the same pain will return once that numbing medication wears off. We do this medial branch block or facet block to, one, like I said, determine the pains coming from these facet joints and which joints are affected. And then once we are able to determine this, we can do a procedure called an ablation, where we take a needle into a similar spot there, and instead of numbing the joint, we essentially ablate or destroy or zap the nerves that go into that joint. So essentially it is like cutting the cord to your TV where the signals don't go through anymore. We're doing that to these joints. So we want to essentially eliminate the body from feeling the arthritic pain coming from those joints. And it tends to be a very good procedure to reduce this pain. It typically lasts for about 6 to 12 months. Usually those nerves will heal and regrow, and the pain will return to some degree in the future, but it's variable between patients. Some patients feel it come back after 6, 7 months. Other patients, year to 2 years, it starts coming back. So it can be a really good way for a minimally invasive procedure that only takes a couple minutes to do, to alleviate this chronic aching back pain for an extended period of time. It also tends to be a very safe procedure because we're not going into the spinal canal. We are not near any of the major nerves or structures of the spine. We are outside the spinal canal, right next to the bones and the joints of the spine there. So I like the procedure because it tends to work, and it tends to be very safe and for patients to undergo. And
I'll add also that it's repeatable, obviously.
Yes.
So let's say a patient has relief for 12 months or so, or even 8 months. They can come back in. We don't necessarily have to go through the injection process again. Typically, most insurances allow us to go ahead and do the ablation again. And the frequency in which we do the ablation may vary, but it does seem to get longer and wider as we do the treatments. Less and less of the nerve endings typically grow back. So we see good results in that sense.
Mm-hmm.
I can talk about a little bit about discogenic pain. A bit more complicated in the sense of how you manage it. and how you treat it. And a degenerative disc can be very uncomfortable, very painful when a patient sits for a long period of time, and they get this pain because of increased compression of the disc. The mechanism is typically understood to be more of an inflammatory kind of, we call them mediators or nerves that are within the disc space that cause pain. And it can cause low back pain, again, worsening with sitting. And the other mechanism is kind of leaning forward and flexion. So you kind of lean forward. If you see this model, as you lean forward, you're going to press the disc, and that's going to create pain as well, an increase in pain. So a lot of patients, and I find this in some of the middle-aged patients, we see that there's a lot of component of discogenic pain. And we often tend to overlook it because we usually chase after like a disc herniation or a facet, issue that we've just discussed. So ideally, a discogenic issue is something that we see changes on the MRI, we see the clinical value and the symptoms. And honestly, many times we go through the motions of doing the treatments, different injections, different treatment pathways, and then we realize like, hey, maybe this is more discogenic pain. And so in terms of going on beyond that, we talked about discogenic pain. Now we're talking about vertebrogenic pain. So vertebrogenic pain is where the vertebrae now are involved. So inside our vertebrae, there's something called a basovertebral nerve. It's a nerve that sits relatively dormant. It doesn't have much function per se, but you compress or fracture the vertebrae, you get pain. If you have a degenerative process that takes over the vertebrae, that kind of eats away into the bone, so to speak, or inflames the bone, that can also activate that nerve and create pain because of the nerve being exposed and or vulnerable. And so on MRI, we see what's called modic changes, MODIC. And what that means is that really means of these it's kind of an inflammatory process that takes place within the bone itself. And so there is a typical presentation for this. It's what we describe as axial pain, doesn't necessarily radiate outside the spine, so it kind of sits there. And it can be reproducible to some degree in terms of location-wise as well, especially if you have, for example, an L4 and an L3 modic change or vertebrogenic change in the patient's area on the spine, or many times they may have pain directly in that area. And it is activity related. In other words, when they do activity, when they do movement, there's some level of compression that occurs because of the disc, but also on the vertebral body. And always we understand that if the vertebral body is weak, it's vulnerable to injury and or vulnerable to pain because of this basovertebral nerve. And understanding a little bit more about it. So when we look at the actual complex, it's called the discovertebral complex. And many of the outcomes and the studies that have been done on it look to see it resulting in, because of a chemical and mechanical sensitization of the end plate nociceptors, meaning there's nerve endings on the end plates of our bone that are also get, affected by this, resulting in vertebrogenic pain. So there's a combination of having those changes on the vertebral end plates, the combination of having vertebral body changes, and that can cause this chronic lower back pain or vertebrogenic pain. And obviously it can be in conjunction with other etiologies or other sources of pain, like, for example, disc herniation, where the nerve is being pinched, and or stenosis of the spine. And as Dr. Bonnette spoke, the facet mediated pain. So we really have to kind of rule out things one by one, or there may be all of them, and the patient may need an epidural and a radiofrequency ablation and a treatment for the vertebrogenic pain. So as I mentioned, the BVNA is a nerve within the vertebral body. So the procedure we do is called a BVNA ablation, or basovertebral nerve ablation. So under X-ray, the same way we would do any typical treatment for the spine where the patient lays on their stomach, what we do is we enter the vertebral body using a needle, a thicker needle, but we enter it under a little bit of local anesthesia, but also a little bit of sedation. The patients we want them more comfortable. And what we essentially do is enter the bone and get to the mid part of that bone. And as we enter into it, we then place the needle and this burning element, we'll call it, to the targeted area, which is typically right at the upper margin of our vertebral body where the basovertebral nerve root sits. So essentially what we're going to do now is when we get in there, under x-ray, we go ahead and burn the nerve. And by burning the nerve, it's like cutting a tree off at the root, and eventually all the branches are going to die. So it's the same concept as when we burn the branch, or the main root of the nerve, then it's going to kill the nerve ending. So essentially you're left with a vertebral body that has no nerve supply or no nerve response, which is perfect because you don't have pain. Typically speaking, this procedure is a one and done in most cases. There are some scenarios where we may repeat it, but it may take up to 3 to 5 years to repeat it. But nonetheless, generally speaking, we try to do it as a one and done treatment. And that's essentially about a 15 to 20 minute procedure. It's very safe, and we can do multiple levels. Outpatient, and the recovery for it is fairly straightforward. A little bit of soreness, and the results are typically seen about 4 to 6 weeks down the road.
Yeah. So, we talked about a couple different ablation techniques here, both the facet ablation as well as the basovertebral nerve ablation. But then the question is, what happens when we do an ablation on the joints of the spine? We try these different procedures, but we still have pain coming from the back itself. And it's still not that typical shooting down the leg type of pain, but just this chronic pain across the back. And that's where peripheral nerve stimulation has really shined as a great option for patients. Oftentimes, there's not a great surgical treatment when it's just this non-radiating back pain because there's not a disc pushing on a nerve and there's nothing to necessarily open up. It's just this chronic pain that's been there for months, if not years. And that's where we start looking at a little more kind of maybe invasive or advanced procedures where we're talking about stimulation of the nerves themselves. So the same nerves that give supply to the joints of the back, instead of ablating them with a needle and that heats up and zaps the nerve, we can place a tiny little wire that will provide stimulation, or it will help alter how those nerves are firing to reduce or change those signals going to your brain that makes you perceive pain. So essentially, I can take a small wire, place it across either one or several of these facet levels to stimulate the nerves that supply these joints and block those pain signals coming out. And typically we use a system called NALU. It's a peripheral nerve stimulator system where you place the lead. First, you do a trial of this for 7 days. Those leads come out of you and are taped to your back. You walk around. We see how much improvement that we get from it. And when you come back and we take those leads out and we determine, hey, there was 75% improvement in pain, that we determined to be a good response. Even if there's only 50% improvement in pain, that is still indicated as a positive response. And we can implant a small little device under the skin that can provide that stimulation to those nerves and gives a continual treatment to these nerves so that we stop feeling that pain in the long run. It tends to be a very good treatment for patients who either failed some of these other procedures or they either had these procedures, they worked for a period of time, and then they're not working now, or for certain patients where it works but doesn't work long enough. That is one of the drawbacks of a typical ablation procedure where you ablate the nerve and it gives great results, but it only lasts 2 or 3 months. And unfortunately, due to how we have to go in, it's not something you want to repeat that frequently, or insurance won't cover it that frequently. So because of that, we have a different treatment option for those patients. It is a nice treatment because it is minimally invasive. It is done through essentially a needle and an incision about a ½ an inch wide. It is nice because even though it is an implantable device that we put into someone anticipating long-term relief, it can be taken out if needed in the future, or if there are any complications. So there's a reversibility to it. And patients tend to tolerate quite well. It doesn't require a long post-operative time. Typically, people are getting relief at their first follow-up appointment when we turn on the device after the small incision is healed up. So it's a very nice treatment option for those of you who have either tried ablations and they're not working long enough, or they don't give a robust enough response to the pain that you're experiencing. Essentially, it comes down to determining where the pain is coming from. As many things in pain management, it's all about finding the right diagnosis and for the right patient. Determining the source. Is the pain coming from the bone? Is it coming from the disc? Is it coming from these joints? And then confirming it with a diagnostic procedure or imaging, and then determining the right solution for them. Do you need an injection to the facet joint? Do you need a ablation to the vertebral body? Do you need some sort of other injectable into the disc itself? Or does it require the placement of one of these nerve modulation or nerve stimulation systems? For all of these procedures, it's all done under image guidance. We're not guessing at where we're going with this. We're using either traditionally X-ray to determine where we're getting this needle in place. Sometimes ultrasound can be used for it for select patients. But it's something that we're able to watch the needle get to the spot that we need to get to. And then from a standpoint of outcomes for an ablation patient, typically if a patient does well with a facet block, they will do well with ablation. And usually 60 to 70% of patients receive up to at least 6 to 12 months for pain relief, and 50% of their pain relief is improved. When we're talking about that BVNA or vertebral body ablation, usually we're seeing 75% improvement for up to 5 years. And then for peripheral nerve stimulation, usually 60 to 80% of patients respond to this type of treatment and get that relief and are able to reduce either the oral medications that they're using or have improvement in their overall symptoms. So we do see really good results with these treatments here, and they tend to be quite durable or long lasting.
We have a quick case study, or a very typical patient that we see with a condition of chronic lower back pain. There's a 55-year-old male, comes into our office and has complained of lower back pain. So, obviously as a part of our differential, we look at, what's going on, what are the issues, how long has he had the pain, and what diagnostic measures and or therapies have been done. So generally speaking, an MRI is very typical of what we would request to have done. And if it's already been done, then we utilize that at that visit to understand what's going on. In this particular patient, he had modic type 2 changes, which are, different type of modic changes at specifically the L4-5 vertebral level. So what does that, help us understand? There is that modic change, but obviously there's other reasons as well within the MRI that could potentially be a cause, like the facet joints and the discs. So essentially, typically a good pathway for this type of patient who has this non-radiating axial pain at the age of 55 is to do a diagnostic medial branch block, which is the small, the needle approach that we numb up the joints there for, with hopeful relief of short period of time, but 24 to 48 hours or sometimes less than that. And then if that works, then the patient gets to a radio frequency ablation, as Dr. Bonnette had explained. And then the final step is if they continue to have some of that sustained pain, then we go to what's called the BVNA because of these modic changes. Now, if the patient came to us and said, I've done all the above and I'm still having pain, but they haven't done, for example, the BVNA or the basivertebral nerve ablation, we will actually get right to that and hopefully give the patient the relief that he is looking for. So again, a very typical patient, between in the age of 50s. More recently, we also see late 40s where, really active lifestyles can lead to early degenerative changes in the spine, or we're just recognizing it more. Patients, we're encouraging them to come into our office, have an evaluation done even at the age of 40 to see what's going on. And there could be a treatable condition like the few that we mentioned that could potentially help long term. And some of the takeaways here are obviously the non-radiating back pain can develop from the facets, the disc, and the vertebral body, which we went through. Main interventions are medial branch block, radio frequency ablation, the BVNA, and then peripheral nerve stimulation, primarily to help with that axial lower back pain. And the pain goal is to reduce pain and have improved function overall. So any questions? So there are some, yes. So there's some information. So the good thing is most of what we talk about is going to be posted on our website. So so any patients that either are listening now and or would like someone else to listen to and so on and so forth, they can access this on our website. We should be able to, and that give it a few days before it gets on there, but it'll get on there. And there are alternative treatment pathways for this, like different types of injectables that Dr. Bonnette had mentioned in disc-related issues. And again, a lot of these are outside the scope of our insurance coverage, and so many patients that when they come in for their consultations, we'll be happy to discuss some of the different options that are out there. The primary treatment pathway, for at least non-radiating back pain is typically focused around looking at the bones or the vertebrae, and then obviously we have alternative pathways there. Any other questions? All right, wonderful. So I think that we're obviously this is a ongoing webinar series that we have. So hopefully we'll be able to host this again in a few weeks. And if there are wishes or requests for our patients, we'll be happy to to take them. Either call our office directly, or if you're a patient of ours, maybe when you're in the office next time, say, hey, I would love to hear more about this, and so on. We'll be happy to talk to you guys about that.
For sure. Yeah. Thank you very much, everyone, for tuning in. And we will be back in a couple weeks. But otherwise, you guys have a great Thanksgiving, and try and stay warm out there with our new cold weather coming through here.
Came in very suddenly.
Yes.
Take care. Have a good evening, everyone.
Bye-bye.
Bye now.